he had just one echo. And his blood test was normal. When he came in the operating room, he had these changes first, then it normalized, then it became like this, and then it became like this. And then you can see that he had these runs of, I don't know what it is. What is that? So when I see that suddenly on the operating table, I was just about to give him an epidural. I suddenly see that. So that is broad QRS. Is it a beta? This one? Anybody who has done a lot of cardiac? I have not done. I think I cannot immediately interpret that. What is it?
Broad QRS is controlled ventricular rate.
So how dangerous is it? You can just summarize that. Even
Patient having patients start getting broad QRS with controlled ventricular rate. If blood pressures and all these are normal, you can still consider it to be, you have to think about it, okay, what exactly the cause is. But if it is hemodynamically unstable with fast ventricular rate with broad QRS, we have always assumed that it's a ventricular tachycardia or something else. We have to immediately defibrillate it, whatever the situation is there. Cardioversion should be done.
so the pressures were normal. There was no serious changes.
Right.
He was talking to me.
Yeah.
And he was asking me when I went to
So then before doing the procedure, you just have to reassess the patients. What are the possibilities of, because in preoperative ECG there is only a single echo.
Yes.
Previously I have one case, an 82-year female lady with anterolateral wall ischemia, history of coronary artery disease, but she is not on regular medications. Physician has done echo, yes son, only mentioned the left ventricular hypertrophy with 50-55 ejection fraction. Same way, I have taken the patient into the operation theatre. I got this kind of ECG, similar with broad QRS complex, and ectopics are irregularly irregular. Sometimes it's a run-off ectopic, sometimes it hold on. I have given a magnesium, but still patient is having the occurrence of the broad QRS are reduces, but still it is getting. We have postponed the case because subacute appendicitis. Surgeon, I have asked with the surgeon, I can wait for 12 hours if you go for a further investigation. Cardiologist come into the picture, he did echo and he finds the hypertrophic obstructive cardiomyopathy.
Yeah.
So these are the ectopics of the ventricular tachycardias because of the hypertrophic obstructive cardiomyopathy, which is missed by MD physician who has done the echocardiography.
Yeah, that usually happens.
So
yes.
that time patient saved, and we just have postponed the case, and surgeon has given antibiotic. 24 hours after, 82-year female lady, pain gone. We will start the oral liquid. So I think surgeon and anesthetist both are happy, and patient is also going to happy. So this is the way you have to just re-evaluate once it is going to happen.
So would you postpone this case or you would go ahead with this case? You find it on the operating table, you find this. What you would do? Postpone the case, yes. So you postpone the case, we give magnesium sulfate, the cardiologist evaluated, and the next day, when he was again brought in, he had the same thing. So this was on the second day. Yes.
I would like to give good anaesthesia with the block along with medicines to make the patient comfortable, because there are chances that because of inadequate pain relief, all these things are happening.
I think what you mentioned is absolutely correct, Kirtan. So we gave him a femoral block on the operating table, which I would have done the previous day of itself, and he would have been more comfortable. Would have inserted a catheter, would have kept it on infusion pump. It would have been more preferable, because this was what that not giving him anesthesia was what the reason was. He was having this when he used to come inside the operating theatre. But even after giving him anesthesia later, he had the same thing. And when I called the cardiologist, he said, "Just go ahead." Why he would say that? He was more confident than me. That he said that he can just go ahead with the surgical procedure. He's not going to have anything. I said, "What about your standby?" He said he doesn't require. So confident he was. We are going to discuss this case in track also. So we gave him a setting position, gave him an epidural, and we finished this case. And the third day he was sent home with all these parameters. He was sent home. He just has that arrhythmias, which will not go off. He has all the medications, but those arrhythmias will not go off. He keeps on going here and there. We get similar type of cases, even for the distal radius. This is just day-case procedure. They just come in, we have an ECG, they have such kind of arrhythmias. You cannot just postpone for that.
But if your arrhythmia, the hemodynamic is stable,
Yes.
then I think it's not much of cause of worry.
Yeah, but it's very easy to say, Ritesh. When you get something and you are alone in the OP, you get scared.
Yeah, I agree to it.
I can share one small experience. When cardiologist used to come and write, can be taken up with due risk. Then I consulted one of my senior anesthesiologists. Sir, why are we asking this reference? So he said when they write, can be taken up with due risk, actually it is not causing anything, but it is just giving me little bit of, encouragement to do all these cases. If we follow this analogy, what I have changed my practices, now I do a lot of basic fit. I am not a cardiologist, but I do put a probe and scan the ventricles, atrium, look at the contractility, IVC. Looking at them, I develop some amount of confidence. What cardiologist is saying is fine. The valves are okay. It gives me some boost. Looking at ECG, if you are getting depressed, increase your knowledge to start analyzing the chambers. You will be confident nothing is grossly wrong. Probably we just need little bit of encouragement to do all this. And of course, I would like to discuss this case with cardiologists in detail.
I want to just add what the cardiologists write, what they counsel to the patient. They usually don't counsel anything to the patient. Regarding the intraoperative problem, you know much better than the cardiologist. So if you find any problem, whatever the cardiologist writes, that's a different thing. You counsel and the patient according to the problem which he can have. I will just tell you a case. We had a bilateral TKR, mother of a very big shot person. He had a severe aortic stenosis, and my cardiologist, a senior cardiologist, he was her patient. He wrote, the patient can be taken up with a moderate risk, a severe aortic stenosis. When I went to do the TAC, I explained about the high risk. He again went back to the cardiologist. The cardiologist came and again wrote the same thing. I told, if you are giving me a high risk consent, I am going to go ahead with the surgery, otherwise I am not. And ultimately, the patient left the hospital. He wrote a big mail to the management complaining against me. The management called me and the medical superintendent asked me, Ritesh, he has written a big mail. I said, you are a doctor, what is a severe aortic stenosis? He told, I got the answer, no more explanation. So you have to be firm on your decision, because if anything goes wrong, you will be caught hold, not the cardiologist.
Very small.